Good evening to everyone. I'm excited about presenting the next week's video YouTube contribution. We have some exciting data to share. I feel particularly honored to be able to present some of this information as I was involved in formulation of some of the standards. One of my mentors in getting my PhD at Duke, Dr. Ed Hammond, I just returned from Duke where they celebrated his 90th birthday. And he's been not once, not twice, but three times the president of HL7, which is one of the big standards in healthcare databases. So I hope to be able to give you some background and some understanding of how all this has evolved and some of the politics and some of the personalities that are involved. So I'm going to share my screen and show a little PowerPoint. I hope you can see this, but as you all are very familiar, since you're involved in trying to get your degrees and taking graduate level courses in medical informatics, information technology and healthcare consumes billions of dollars every year. And I got started in the industry in the 1970s, before there were computer systems that were interactive. It was all mainframes and big tape drives, and hospitals were not nearly as large a business as they are now. Currently, the healthcare system consumes $4 trillion in America, and 34% of that money, so about a trillion and a third, goes to hospitals. So it's a huge business, and the hospitals have a very clear orientation to be sure that they get paid for everything that they do. They when I first went into medicine, almost every hospital was nonprofit. This dates back to some legislation in Congress called the Hill-Burton Act, which provided funding to many counties, especially rural counties, to build hospitals as long as they promised to provide services independent of a person's ability to pay. And so we found a huge growth in the number of hospitals in America. And we've seen recently some consolidation, and some of the smaller hospitals have not been able to survive all of the complexities and intricacies of the current systems. But we need to have a little bit of some background and some understanding of how the system got to be as big and as dysfunctional as it currently is. So the doctor's offices, the primary care practices, were still using paper records until the late 1990s, early 2000s. And so the concept of electronic health records was something that has really grown from the hospital systems. The hospitals knew that in order to get compensated for the services they were providing, they were going to have adequate documentation. And the easiest way to do that was with electronic health records. And so you've seen the major growth of the electronic health systems, the electronic health records in hospital systems. And at one time, there were nearly 30 national vendors of hospital information systems, and that has very rapidly concentrated in the last few years, to the point now there are only a half dozen that are left, and really only three that have much influence in the bigger marketplace. The major vendors now are Epic, which is what the big hospital in Columbia uses. Prisma uses Epic. They used to be a Cerner shop, but when they were taken over by the Greenville Hospital System, when it became Prisma instead of Palmetto Health, they made a conversion from Cerner to Epic. And the third big system, so the two big systems that we're talking about now are Epic and Cerner. Cerner was purchased by Oracle, and Oracle, as you know, is the organization that runs SQL, the SQL developer that we use a lot at Carolina. So SQL was a big Oracle product, and um, so when they purchased Cerner a few years ago, they they have tried to make significant extensions and expansion. But unfortunately, the timing was not very good. Several other complexities have muddied the waters. Cerner um, and Oracle uh, went for a long, protracted contract bidding war to be able um, to provide updating of the Veterans Administration's medical information systems. And that's really a very complicated political issue. It's a multi-billion dollar 10-year contract. And of course, the other competitors fought hard, and Microsoft wanted a piece of it. So that the a contract of that size ended up in lots of litigation, but Larry Ellison and Oracle ended up winning out. But it's been very confusing and distracting to the Oracle folks because the VA system was so used to doing things in their own unique way, and since they're not really interested in trying to bill the patient or bill insurance companies, their motivations and their priorities were very different, and so they've had a very difficult time trying to implement a system. Historically, the Veterans Administration's information systems have served them well, but they're antiquated and a little bit inflexible. But it's very difficult to try to install a for-profit type information system into the Veterans Administration's healthcare delivery system, which is really focused on patient care, not on money and profits. So the hospitals obviously have taken the lead in electronic health records. There's been some legislation, the HITECH Act and CARES Act was national legislation that was trying to encourage doctors to make the transition to electronic health records. And because it's a massive undertaking, many of the small practices, especially primary care practices, could not really afford to make those transitions. And so we found, whereas when I went into practice in the 1970s, 90% of doctors went into private practice. Now 90% of doctors are become hospital employees as soon as they finish their training. So we've seen a major shift because a lot of it is because of the infrastructure and the demands of the electronic health record. And I think it's important as you're taking this course in healthcare databases to get a perspective from a practicing physician that was in the trenches for 50 years, who can tell you that that one of the biggest causes of burnout in medical practice is the electronic health record. The electronic health record to the doctors requires just tremendous volumes of information, and the structure of the data is often not very flexible and not very friendly. And so the doctors end up spending many hours trying to interface with computers to try and capture the information, sufficient information to get reimbursed for the services they provide. And it's a very dysfunctional system now, and doctors are unhappy, the hospitals are unhappy. But there's a lot of money involved. Like I said, $4 trillion, nearly 20% of the gross national product of America goes towards healthcare. We spend more than double what most other countries spend per capita, and yet we deliver uh, pretty pretty bad services. So uh, the bottom line is that I'm glad that you all are taking this course. I'm glad that you can become leaders. I hope we can have a lot of interactive discussions about the frustrations and the challenges towards trying to provide high quality care for a reasonable cost using information technology. So the initial use case for the health for the medical information systems for the electronic health records was for the hospitals to get reimbursed for the services. But now we're trying to look more at delivering better quality care and more efficient care. And I'm very excited about the point in your careers that y'all are now, that we have all of this attention being paid to artificial intelligence and the potential for artificial intelligence to dramatically change the way the primary care physician and providers of specialties providers also are able to change how they interact with the system. And so that's one of the things that we'll be talking about tonight, is to figure out, what are the standards, what are the challenges, what are the problems, what are the barriers, and what we see in the foreseeable future. Do we see some changes that are coming down the pipe sometime soon? Next slide. So let's talk about HL7. HL7 is an international organization that was developed to try to get some standards among the various healthcare information systems providers to be able to talk among themselves. And if you see on the slide here, there's HL7 was founded by a group of healthcare professionals, including Ed Hammond. Ed Hammond was the professor at Duke that I initially studied under, and we created the very first paperless medical record for obstetrics back in 1972. So I've had some involvement with some of the leaders and some of the pioneers in the areas of HL7 and trying to come up with some standards for medical informatics. But the entity that HL7 came out of was an international standards organization, and a lot of their meetings have been in Europe. But it's exciting that the goals are very clear, to try to figure out how to have some intercommunication, some interoperability between these various monolithic information systems, and it's not done well. The various vendors feel like they should be able to control the environment, and that does not really help the end users. The end users don't usually get much of a voice. And so over the years, since HL7 has not really fostered the ability for a patient to go from one facility to another and be able to take their records with them, or to have the systems talk to one another in any intelligent fashion, they more recently came up with a new set of standards called FHIR, which is Fast Healthcare Interoperability Resources, which is an outgrowth of HL7. And it's very simple what they tried to do, and it's very straightforward. It makes a lot of sense. They realized that HL7 standards were trying to micromanage little intricate, very detailed fields, and it just wasn't working. That no one would accept the standards. And so when they put together FHIR came up with a very simple and straightforward policy that they were only going to implement 80% of the fields that were commonly used in the various hospital environments. And so by making this decision, when someone had a new area that they wanted to have a standard developed to be able to intercommunicate for interoperability, it went to the committee, and unless the committee thought that more than 80% of the users would be willing to agree to a certain standard, it was not submitted to the standards organization. And so this has really slowed down the ability to have any meaningful interoperability when only 80% of the fields are developed to a standard that they can be interoperable. So that's where things stand. So HL7 and FHIR are the current international standards, but in reality and practice, they have not gotten very far in terms of allowing a patient to go from one facility to another and be able to have the two facilities talk to each other meaningfully in terms of sharing information. And so there are some areas, there's some applications that have done better than others when you're talking about trying to have the entire record be transmissible between facilities. We are nowhere near that, but there are certain subsystems that have turned out to have much more urgent demands, like X-rays and CAT scans and EKGs and certain imaging files. And so standards among radiologists developed called DICOM um, early on in the history of medical informatics, and so they've been able to share data, uh, imaging data, for a long period of time because they had a use case and patients that were having imaging done and were in the emergency room and then moved from one hospital to another needed to be able to transmit those original imaging files, and so they're very sophisticated and they do a really good job. But in terms of taking a patient that's a patient at a facility that uses Epic and another hospital where they're using Cerner to try to say, is there some way that we can just download all of the medical record from one system and then upload it into another system? That is not happening, and that is really sad because that's really really hurting us. So that brings us to the bottom line opportunity that we need to look at, although it's not actually operational. But there's an expert in India, Siddharth Ramath, who's a real proponent. He's a physician. Both of his parents are ophthalmologists, and he went to medical school thinking that he was going to follow in their footsteps, but he got so enamored with programming that he didn't finish his ophthalmology training and is instead working as a medical informaticist. And he has recognized that the extreme frustrations that we have with trying to do the interoperability and trying to communicate medical records. And he recognized that there is one international standard called Open EHR, Open Air, that that takes things all the way down to the JSON, HTTP level, and has the flexibility and the potential to be able to have records totally interoperable. And I foresee the time in the next couple of years where you'll be able to roll out a record from Epic into OpenEHR and then open it in a Cerner environment from OpenEHR to a Cerner record. And that is our ultimate goal, is to be able to have the data, the medical electronic health record should belong to the patient, not to the facility, not to the hospital system, not to the health system. It should be the patient's data, and it should be at the elemental level where every variable is in a format that can be rolled out of one system and into another. And that's our goal. That's our dream, is to have interoperability to the point that we can take data from one hospital information system, electronic health record, roll it out into a standardized format that may look very complicated, but includes all the standards that allow you to have every element of data, whether it's a blood pressure, a pulse reading, a blood sugar, a patient's weight, their temperature. All of those variables have to have some standardization of their structure so that the data can be shared among facilities and the data can be back to the point where it belongs. And that is, it should be the patient's data, not the hospital's data. And so that's the future. I hope that all of you that are in this course can help further the discussion and figure out how we can get away from these proprietary systems that are doing nothing but causing a continued increase in the cost of healthcare and continuing frustrations that we're not able to share medical information from facility to facility, and the patient ends up being the loser. Thank you very, very much.